Hello everyone, I'm Donna Marie Young, medical correspondent for In the Know News, an independent news agency committed to finding the answers to your questions. Over the past few years, there have been multiple reports of outbreaks of a nightmarish bacteria known in the medical industry as CRE, carbapenemum-resistant Enterobacteriaceae. This antibiotic-resistant bacteria, or superbug as you've heard it called, has the potential to infect and kill. And there are outbreaks. We've heard you ask, how can this be? How can a deadly bacteria pass from one patient to another when the patients do not have direct contact with each other? And how can it happen in different regions of the country over a period of years? We've heard you ask this question. The answer is that the outbreaks have been directly associated in the exposure to a medical device called a duodenoscope. What is a duodenoscope? It is a medical device inserted down the throat and is used in a life-saving procedure called an endoscopic retrograde cholangiopancreatography, ERCP procedure. The most recent report of an antibiotic outbreak was from the UCLA Medical Center. Hospital administrators there had to contact 179 patients who had undergone an ERCP in the latter part of 2014 and the beginning of 2015. They were urged to be tested, and of those 179, 7 patients were found to be infected. Of those, 2 died. How did this happen? How can this possibly happen? An investigation was launched, and it was determined that there were no breach in the reprocessing protocols, nor were there any defects found in the duodenoscope. What was discovered, despite medical device reprocessing staff adhering strictly to the Society of Gastroenterologist Nurses and Associates, or the SGNA guidelines, which are here, they have very strict protocols in which to follow when they are reprocessing and disinfecting and cleaning these scopes. They have to do a pre-cleaning, a leak testing, manual cleaning. They rinse after the cleaning. They do a high-level disinfection, either manually or automated disinfection, and then another rinse after this high-level disinfection, followed by drying, and then they have to correctly store these duodenoscopes. So the staff has followed the SGNA guidelines. They've followed the guidelines laid out by the manufacturer, and they followed the UCLA Medical Center's own protocols. None of these guidelines were breached. What was discovered was that despite all of the aforementioned steps taken, positive microbial cultures were still found within the complex design of the scope. The FDA, or the Food and Drug Administration, engineering assessments have identified design issues of the scope that complicate the reprocessing of these devices. Some parts of the scope may be extremely difficult to access, and effective cleaning of all areas of the scope simply may not be possible. It has been noted that the elevator mechanism and all its moving parts contain microscopic crevices that may not be reached with a brush. Residual body fluids and organic matters may remain in these crevices, and if they are contaminated, future patients may be exposed to serious infections, even after the device has been cleaned and disinfected, as is this case. It's ironic that the complexity of the design that improves the efficiency and effectiveness of the ERCP procedure is what challenges the cleaning and disinfecting of the scope and threatens lives. So you ask, what is being done to prevent this unfortunate incident from occurring, either in the same facility or elsewhere? Well, the CDC, the Center for Disease Control and Prevention, along with the FDA, the Food and Drug Administration, recommended that the MDR staff meticulously clean the elevator mechanism and the recesses surrounding the elevator mechanism by hand, even when using an automated endoscope reprocessor. They are to raise and lower the elevator throughout the manual cleaning process to allow brushing of both sides. This is in addition to following the CSGNA standards and the CSA reprocessing principles. So as you can see, there's all sorts of documentation and guidelines that they need to follow, and they are being followed. And the CSA reprocessing principles 8.1.2.2 states, the cycle of infection can be broken by cleaning, followed by disinfecting and sterilized medical devices. So that's the first recommendation that came out of the UCLA event. The second recommendation made was to implement a comprehensive quality control program for reprocessing duodenoscopes. The reprocessing program should include written procedures for monitoring training and adherence to the program. They need to document the equipment tests, the processes, and quality monitors used during the reprocessing procedure. This is a good thing, in my opinion. This second recommendation pertains to and augments the existing CSA Standards 5.1, which addresses the Personnel Education and Training Standard, the 5.2 Worker Health and Safety Standard, and 5.3 the Reprocessing Program. We need our people to be highly trained and educated. They understand what's going on and they know what it is that they're doing. And these standards, the CSA standards, address those issues. Even though the duodenoscopes are inherently difficult to reprocess, strict adherence to the manufacturer's reprocessing instructions will minimize the risk of infection. Deviations from the manufacturer's instructions for reprocessing may contribute to contamination. This was fortunately, no deviations were found. This is not the case. It is the actual design. In 2014, at the Virginia Mason Medical Center in Seattle, an investigation was launched into an ERCP-related outbreak there, where 35 patients were colonized with the bacteria, and 11 of those patients died. This outbreak was again directly related to 4 contaminated duodenoscopes. We have documentation here on the report and the study through that. The investigation revealed that a particular mechanism of the duodenoscope, what they call the elevator channel, harbored the pathogen. This particular pathogen, HAC, the hyperamp-C E. coli strain, was identified to patient strains that were cultured directly from the elevator mechanism out of 4 out of 8 duodenoscopes carried this virus over a period of several months. This is the complicated mechanism within the scope that was the issue at the UCLA Medical Center outbreak. So again, it's telling me it's a design issue. The same deadly issue generates the same concerns. And what is to be done? Well, out of this investigation, in addition to implementing the previous recommendations of following manufacturers' cleaning processes and facility protocols, the Virginia Mason Medical Center hired a full-time microbiology lab technician to monitor the efficacy of the medical device reprocessing results. That's a good thing. And to monitor the quality control program. It was told to me earlier that the quality control people were culturing the scopes after they had been reprocessed. And this satisfies the CSA standard number 9, process verification, monitoring, and adverse events. And it addresses the Public Health Agency of Canada, the PHAC, Infection Prevention and Control Guidelines, standard number 6. And those are here. Recommendations for outbreak investigation and management, where investigation into a suspected or confirmed outbreak will determine the potential routes of transmission. Protocols are being followed. Everything is being done to find out how these infections are occurring. No breach of protocol is happening. It is in the design. When deviations were discovered by the quality control staff while culturing the reprocessed scopes, the still contaminated scopes were being quarantined and then reprocessed and retested to ensure that no bacterium was present before it was entered back into the procedure rotation. These steps would be part of that comprehensive quality control program, which was, again, another recommendation that came out of the UCLA investigation. For me, it's comforting to know that positive steps are being taken to combat this very scary and very real problem, but I'm wondering what else can be done to reduce the risk of infection transmission. The Virginia Mason Medical Center purchased an additional 20 scopes, increasing their inventory from 8 to 28 at a total cost to them of $750,000, $750,000, which is a substantial investment in addressing the problem and limiting the risk of transmission. So that's another good sign that things are being taken very, very seriously. Given that 2 of the recent outbreaks were found to stem from the same internal mechanism, in my opinion, it's ultimately a product redesign that will curtail the outbreaks. A total redesign will address the intricate moving parts that harbor the deadly pathogens, but I can only assume that will take a long time. And in the meantime, immediate changes still need to be implemented. And sitting behind this desk in front of the camera, I wonder, is the solution as simple as enhanced cleaning methods? Well, maybe if that question had been addressed back in 2013, where at a third outbreak occurred at Chicago's Advocate Lutheran, 6 patients were affected and 2 patients unfortunately died. The outbreak in Chicago caught the attention of Dr. Lawrence Muscarella, and he linked the contaminated gastroenterology scopes used during ERCP procedures not only to patient colonization and infection, but to patient mortality. And here are the reports and the investigation into that. Dr. Muscarella recommended healthcare staffers contact the scope manufacturers and request specific instructions for thorough reprocessing scopes that feature the forceps elevator, the elevator wire channel, and the non-removable Distal hood. This was yet another report identifying the complex inner workings of the duodenoscope as problematic and can pose a particular challenge for effective cleaning and disinfection. Well, it's no surprise that all 3 of these outbreaks were contributed to this design flaw. But I ask, and I've heard you ask, if this was identified as early back as 2013, why hasn't something been done about it yet? Why? Maybe Pentex and Olympus are working on a redesign. We don't know. We haven't had any reports. But until that new product has been redesigned, tested, approved, rolled out, purchased by the facilities, and the existing inventory is replaced, I ask, what else can be done? Well, one of the recommendations revealed ETO gas sterilization. Actually, it wasn't recommended, it's been mentioned as a possible adjunct to regular high-level disinfecting. Although empirical data supporting its effectiveness is slim, the CDC intimated that it was indeed the ETO sterilization process that stopped the outbreak at Advocate Lutheran in Chicago. This outcome may have been due as much to ETO gas's sterilizing effectiveness as it being a dry process. The automated process is a wet process. The sterilization, the ETO gas sterilization, is a dry process. Perhaps there's a difference in there. Another issue that presented itself with regards to this specifically is the possibility that rinse water or tap water used in the process was contaminated and was unfortunately reintroduced back to the scopes. This was not verified nor excluded as a source of contamination, since no test was done on either source, but it is being floated as a possibility. And so that possibility would substantiate the ETO sterilization, the dry process. Another investigative report on CRE outbreaks suggests that due to the hardy nature of the organism, CRE can develop and grow in biofilms, and that they can contaminate sinks and grates and drains at hand washing stations in the healthcare setting. This would indicate that an outbreak is not exclusively a patient-borne bacterium. So even though these reports indicate that the outbreaks come from the intricate dealings, the inner workings of the duodenoscope harboring the pathogen. It could be that our sinks are also harboring the pathogen, and when water goes down on the sinks and splashes up, those pathogens are passed on to our hands. There's just not enough research and relevant data available yet to definitively answer all of the questions we have. Until the medical community concludes its research, we the public must simply put our trust and faith in the facility where we have our procedures done. We have to hope that of the 500,000 procedures done annually, you are not one of the small minority that contracts a deadly infection. I'm Burak-Young, attempting to answer your questions. Thanks for watching.